So fast forward to 2016, and there was a clinical update again in the American Heart Association's journal called Circulation. They outlined this very useful and practical schema for the baseline evaluation of patients being considered for ADT. And what they show you here in this slide is the Abcde algorithm for prostate cancer survivors, which I think is worth its weight in gold. So it emphasizes awareness, aspirin 81 milligrams for primary and secondary prevention here. And I would emphasize that there is actually data that aspirin works not only for cardiovascular health, but may also have a role may also have anti-tumor properties. In fact, there was a study not too long ago that said that this is beneficial for prostate cancer specific mortality. So something to definitely consider. The B stands for blood pressure control. The goal blood pressure in this document came out in 2016 was less than 140/90. I would argue that today in the day and age of sprint trial and everything that we know since then, you could argue that we need to go even lower to a target blood pressure of 130/90. Again, high intensity statins for patients with hyperlipidemia or a high ASCVD risk score or pre-existing cardiovascular disease or diabetics. Very, very important. We know that statins work not only by cholesterol lowering, but they have pleomorphic effects. Cigarette smoking absolutely needs to be discouraged. You need complete abstinence. We know that it is an independent and negative prognostic factor for prostate cancer specific mortality as well as all-cause mortality in patients with prostate cancer. Diabetes mellitus, we talked a little bit about what to do for screening of these patients. Metformin, it's beneficial for patients with metabolic syndrome. So that's definitely an option for patients with pre-existing cardiovascular disease. Now there is multiple new classes of medications for diabetes. Those can be opted for. They have a positive effect not only on diabetes control, but also have shown beneficial effect on cardiovascular disease specific mortality. So those are the newer generation of medications that should be preferred. And then I cannot overemphasize the importance of regular regimented exercise programs. It turns out there is a wealth of data that has been coming, which is showing that not only does regular regimented exercise mitigate some of the side effects of androgen deprivation therapy, but can also help mitigate some of the cardiometabolic aberrations that we are seeing. So definitely that has to be counseled for the patient.
Dr. Gupta, what happens if somebody is not on aspirin? They're on Pradaxa or Eliquis, and we have patients who have stents and they're challenging enough from that cardiac risk.
Yeah. So I think putting patients on anticoagulation as well as antiplatelet therapy should be done in collaboration with their primary care providers, cardiologists, interventional cardiologists, because we oftentimes balance the thrombotic risk against the risk of bleeding. And so I would say that is a decision that has to be made on a case-by-case basis in a multidisciplinary environment, just like we do. So back to the real-world patient with prostate cancer. So we've talked a lot about what we should do, how we do manage these patients at our institution. So this was a patient that came through our doors. So just to recapitulate, 72-year-old obese male with diabetes, hypertension, dyslipidemia, coronary artery disease, had an inferior MI 1 year ago with prostate cancer going on ADT. So definitely a high-risk patient. Blood pressure 160/90, heart rate of 70, a high BMI. He was on aspirin, toprol, lisinopril, pravastatin with an LDL of 120, glipizide of 10 milligrams with a hemoglobin A1C of 7.4. Further testing was all unremarkable. So we engaged in an extensive risk-benefit discussion. We clearly outlined for the patient that he's going to be high risk. We went through the Abcde model that we talked about, and in terms of lifestyle modification, et cetera, we reviewed the diet and exercise goals with the patient. We changed the statin therapy to a high-potency statin because this patient does have a known coronary artery disease, would benefit from that. We substituted metformin for glipizide. We increased his lisinopril because clearly he's not at goal blood pressure. We advise that he keep ambulatory blood pressure logs at home and bring them to the appointment so that we can continue titration of his antihypertensives. And then, very importantly, we went over the symptoms that would necessitate immediate medical attention for this patient if he were to have acute coronary syndrome or other complications. So to summarize, androgen deprivation therapy is associated with increased cardiovascular risk. GnRH antagonists may be safer than GnRH agonists. The short-term cardiovascular risk is highest in patients who've had cardiovascular adverse events in the year prior to starting androgen deprivation, and appropriate referral to primary care providers and cardiology for primary and secondary prevention and multidisciplinary collaboration is really the key to successfully managing these patients and ensuring an optimal outcome.